All right, does that look okay, everybody?
Yes,
Okay.
that looks perfect.
So today we're going to talk really specifically about medications to treat nicotine and tobacco use disorders and some very pragmatic and practical approaches. I do want to put out a plug for anyone that's really passionate about this. I am also part of the Certified Tobacco Treatment Program through the School of Dentistry that is an internationally recognized program for educating people in this that comes with a fancy national certification in tobacco treatment. And if you are interested and passionate in this topic, we want to recruit every level and multidisciplinary approach to this. That program is in May. It is a 3-day program. I believe it's the 18th through the 20th of 2023. It is available to you and you can achieve the certification. But this and many of the motivational interviewing things that we've done before are part of my passion projects coming from that as well. So I will try to do it justice in an hour to really provide some basic pharmacology, but this is just such a critical aspect for folks. All right, I get off my soapbox. So today we're going to really talk about the different forms of tobacco use. And I'm going to propose to you a different way of thinking about this in terms of treatment and how you assess it. A lot of times people have focused on how many cigarettes someone's using or how many cans someone's using of smokeless or how many pods or what I'm going to really urge people to think how many milligrams of nicotine are being consumed in a very biological way to meet the need. So for many people, that's a different way of doing assessments regarding use. And although knowing the details of all those things are important for other health outcomes, to really treat someone and meet their need, really thinking in milligrams per day is what I'm going to ask you to change your thinking about as we approach this, because that is definitely a frame shift for a lot of people. And then we're going to take that milligram-based knowledge and really translate it to meet people's needs, their cravings, and their withdrawal symptoms to really improve outcomes for cessation, alongside all those motivational interviewing and other therapeutic techniques we talked about. So I think it goes without saying, and we could do a whole presentation on this too, but nicotine is really a master manipulator and one of the more perfect drugs in terms of getting people hooked. It really goes to the brain in about 7 seconds and causes a biological response, often for people that have use disorders, an immediate response that's very hard to break. And despite that, and it has been engineered that way by tobacco companies, most people want to quit. And if you survey people that are using tobacco products, 70%, regardless of their age, their product they use, want to quit. However, most of the time they aren't really sure how, or they have had treatment failures in the past that may not have lived up to what they needed to be successful. And so it's really important, I think, to acknowledge and use those motivational interviewing skills to really get at that 70% of people that do have reasons or want to do so, but for whatever reason may feel that they cannot. So this comes back to the milligram theory. And if you think about thinking in milligrams, we can really label the amount of nicotine in a lot of products. And so these rules for treatment can kind of occur regardless of where the nicotine is coming from. Now, I will say the limit to this is as you use a product, you can change the amount of milligrams in the product by the way you smoke it, how long you hold it in your lungs, whether you let it burn it off. So this is not perfect, but it does get much closer to what someone's needs may be than probably most other approaches. And what I would say clinically, what I've discovered is most people, especially with NRT, specifically, that's nicotine replacement theory, the number one reason that I see why people fail is that their coverage needs from the NRT, the nicotine replacement therapy, did not match their daily use in milligrams. And that is a fundamental reason why it will fail and often fails. And so it's very critical to know that. For the prescription medications we talk about, the milligrams aren't quite as important in terms of treatment, but it can help you understand that maybe combination treatment or multiple avenues of treatment may be indicated, especially when people are using typically more than 25 milligrams of a nicotine product a day, moves people into a high use category that may justify different levels of treatment. So a basic cigarette typically has around 1 to 1.5 milligrams of nicotine. So for simplicity, 1 cigarette equals 1 milligram. So if someone is using 1 pack of cigarettes a day, 1 pack of cigarettes has 20 cigarettes in it, we think 1 pack of cigarettes equals about 20 milligrams of nicotine. So in your assessment, you're asking people how many cigarettes on average are you using a day as well. And if people use multiple products, you want to add it up, trying to get the best daily average for what they're using currently. And it is important to do currently. This is a rapidly neuroadapting phenomenology. And so what they used 2 months ago may have, or 4 years ago, may have impacted cancer risks or other health issues, but it is not going to help you treat their level of addiction today. So it is the best month on average guess that you can come up with. Cigars are a tobacco product where the tobacco is wrapped within a tobacco leaf. The large cigars that you often see Arnold Schwarzenegger on Cigar Aficionado, 1 big cigar is equal to about a pack of cigarettes. So that's about 20 milligrams. And that is a lot more than most people think it is. Fun fact, cigar use is actually one of the few tobacco products that affects high SES folks, more so than low SES. And it has become a what's the word, luxury product, but still a substantial and significant amount of nicotine. The little tiny cigarettes, the cigarillos, often are very attractive to females, and targeting females also contain a fairly significant amount of nicotine. So while it looks the same size essentially as a cigarette, it has about 3 milligrams of nicotine in it. So if they are using the little cigarillos or little cigars, you want to find out which one they're using. You're probably getting more than a traditional cigarette. A hookah. We do have some hookah bars in the state. This has become a popular and often cultural socializing phenomenon, but about 1 hour in a hookah bar around using a hookah also delivers about 20 milligrams of nicotine, about 1 pack of equivalent of nicotine from cigarettes. Smokeless tobacco, while nationally only about 3% of the population use smokeless tobacco, anyone want to venture where West Virginia ranks in our smokeless tobacco use? Yes, it is indeed #1. Us in Kentucky battle it out, and it's not even close. The overall percentage rate of smokeless in West Virginia is 19% around our male population. That is a phenomenal increase, and this is a cultural phenomenon. This is the outcome of the coal industry. And we are targeted by advertisers for this product because you can use chewing tobacco in the coal mines, but you can't have an incinerated product. So this has been a highly engineered in Appalachia and culturally for our population. And this is a very shocking statistic, and it is not an uncommon thing that I have people that use 1 can of smokeless a day. The best way to screen and ask about this is to find out which brand they're using. In West Virginia, Copenhagen and Bandit, is it Bandit? No, Grizzly, I'm sorry. Copenhagen and Grizzly capture a huge part of the market share. And they have really engineered their tobacco products by really making this very high basicity alkaline substance so it can absorb more nicotine. And so 1 can of chewing tobacco is equivalent to 4 packs of cigarettes a day, 80 milligrams a day. So you want to ask people, how long does that can last you? how many cans are you using a week, so that you should try to understand how much they use. And this population can be very challenging to treat, because if you don't realize how much they're using, you will likely undertreat them substantially when it comes to NRT. And then the client or patient will feel like they failed, when really it was our failure to not match their need. And so it's really important we understand that. I will say, if they're not using Copenhagen and Grizzly, or they're using some of the other products like snus, and they can all be quite different. There are articles that look through all the different products and estimate how many milligrams. So if you get very savvy, you can look at it by product per se, but these are by far the share in West Virginia. So I want to talk a little bit about vape. As I said, vape probably warrants its whole, or electronic cigarettes probably warrants its whole individual lecture in many ways. So this is a very short version of that, but this is essentially a device that allows the inhalation of still nicotine, often through a non-tobacco product. So this is could have tobacco in it, but often the solvents or the chemicals or the neutral reactants are often the liquid, or whatever you want to call it. The hook is usually that all of them contain nicotine as the addictive agent to bring them back. And while initially it was sort of thought, oh, maybe these will replace and be a cessation product because we're helping people meet nicotine, we are really learning a great deal about most vape devices, that those solvents, the polyethylene glycol, the other substances in them actually have their own risks and toxins when heated. And so although there is a lot more coming out regarding this, I will just sort of say that the health risks of vape are coming out more and more to look just like the same risks of other tobacco products. And we can talk more about that at length, but it is a very hard, especially among young people. Many of them do not realize or consider that vape products are similar to tobacco products, although it is the nicotine that crosses that. So when you're screening and asking, it's really important you ask about vape or electronic cigarettes very specifically. If you have an only e-user of a product and you ask about smoking or tobacco, they will say no. That being said, as I show you some of these slides, when we get to that milligram theory, you will see that some of these products have enormous amounts of nicotine in them. And many people that are using vape products really cannot quit without cessation treatments because of that. And so there have been multiple position statements, although none of the medicines we're going to talk about are FDA approved for vaping per se. Many health agencies, including those for children, have indicated that many people will not be able to stop vaping without cessation pharmacology, given the amount of nicotine in these products. So I do want to spend a little bit of time. So we don't see these much anymore. These were your first generation devices. You will see that as we go through this, all the devices have three main components. On the one end, there's a battery, and the battery creates the heat to heat the solvent. There's the device where it's stored, and then there's like the mouthpiece and area of these. The second generation, and you'll see them grow, is what people discovered is, in order to really get that nicotine in an inhalable form, you need a lot of heat. So you would see the batteries get bigger and bigger and bigger. And so you see this battery being much higher. You start seeing them have charging ports and ways to add additional energy to heat that tank, to vaporize it so it can be inhaled. The third generations, you're seeing the very giant batteries on top of these. And with the second and thirds, you could buy the products and mix them yourself. And you would see people also adding flavoring and other substances. And a lot of the flavorings also had sort of toxic chemicals in them. You'll see things like heavy metals inadvertently getting added that can cause their own health problems. But again, all of these solutions had usually some form of nicotine in them. Certainly these that are adjustable and you can sort of personalize your device, you're seeing other things being inhaled. THC being a very big one, as well as other things that sometimes can be in the devices. What has sort of emerged and been kind of fourth generation and caused an enormous amount of increase in sales, of which now Juul has been sued and facing a lot of financial implications because of targeting youth. But these were the pre-filled sort of versions where you would just go pick it up. You didn't have to mix it. The solution was there, the nicotine was there, and you picked up your pod, your fixed pod. It does make it easier to figure out milligrams when they're using a fourth generation, because each brand usually has a set amount of nicotine at the label of the device. When you were dealing with the second and third generation, when people were mixing them, those were the hardest ones I had to figure out the milligram conversion. So just again, for some comparison, and I will tell you that these are just 3 examples, but if you go to look and if anyone goes out on a holiday and wants to check out a vape store, there are literally 200, 300 different brands. It's very overwhelming. And these brands maybe are not even probably the biggest market share right now. Puff Bar has increased dramatically, but you'll see an evolution of the amount of nicotine coming through in these products. So we go back to our 1 pack of cigarettes equals 20 milligrams, right? The Juul pod, which was an emerging device that really sort of started a lot of this trend. 1 Juul pod was about 40 milligrams or 41 cigarettes. The fix came out and you're seeing each pod being about 75 milligrams, and the Sorin up to 90 milligrams. So these are massive amounts of nicotine compared to a standard pack of cigarettes. And so when you're, again, assessing and asking, you want to know what brand they're using and roughly how long a pod or cartridge lasts. And you can look all of them up to try to see. Now, again, there is a lot of this is becoming an area that people are getting more nuanced in. A new user of a vape device is probably unlikely to extract all 40 milligrams when they're inhaling it. There are techniques in how you hold it in and how you consume it, because it goes across the mucous membrane. Usually in some of these forms, how much you get out of it, but the general rule is that you're getting out substantially more than what a pack of cigarettes equivalent would be. Okay, so is there any questions about the milligram sort of piece of this? Because that is really the foundation of a lot of the treatment, especially for the NRT. Does that make sense to everyone? Okay. All right, so although I did my last presentation on motivational interviewing, and motivational interviewing is a very effective technique, that the idea of someone that truly has a nicotine use disorder just being able to quit, given the intense biological cascade that often happens and withdrawal profile, just telling someone they need to quit is really not going to lend to much success. And so I think it's really important to remember that on average, the cold turkey, I can just quit on my own with no help, success rate is only about 5%, which is really not very successful at all. And so it's important we know that, because I'm going to show you some of the statistics on these medications, and they're not going to look great to you. They're not going to be 100%, but you need to compare it to that 5% that happens without it. And I think that's a very important understanding. It's also, I think, really helpful for our clients and our patients for us to know how hard this is, and that we're really helping them in any way we can be more successful than 5%, because there are definite ways to increase success. So this, we'll get into more of the details about each medication later, but this is the general efficacy rate at 6 months, so 6 months of abstinence of each product. And again, you'll see placebo maybe a little bit higher at 13% in this study, but you're going to see that varenicline or Chantix is the highest rate on this monotherapy list. And that comes from some recommendations we're going to talk about. If you can only pick 1 or 2 things to do, what could you pick? And varenicline is definitely in the contention because of that high percentage rate. We're going to talk about these other things, but 33% at 6 months is substantially better than 5%, right? A huge 6-fold increase of success. But I also think it's important to note, and you'll see this on the next slide too, the other choices are also substantially higher than 5%. And so sometimes it is important to personalize choices. And if a client comes in saying, I want nicotine replacement or I want bupropion, those success rates, even though it may not be as high as varenicline, is still better than nothing. And so we really want to acknowledge how much better we do in helping people be successful if we effectively combine the correct medication for them. We're going to talk about combination therapy. Combination therapy can be combining a prescription medication with NRT, or it could be combining 2 prescription medications, but the most common form of combination therapy is combining the patch, which is the long-term release that we're going to talk about, with an ad lib add-on, such as gum or the lozenge. And you see those rates getting up to about 36.5%, again, substantially better. So in a lot of the algorithms and recommendations that have come out from like the American Academy of Cardiology, the answer is, if you don't know where to start and you want to start your first line treatment, and this even comes from people that are admitted with a heart attack, you should offer all people with a clear nicotine use disorder either Chantix or combination NRT with a patch and an ad lib medication as your first line treatment if they do not have another preference, because those have the highest success rates in first line. And again, I will say that NRT has to be dosed appropriately for the amount of milligrams that we're going to use. So when you see those recommendations coming, although all of them have efficacy over that, you do not want to negate anything that they may want to try. I will point out there are 2 medications there that are not effective. Naltrexone does not help smoking cessation, and SSRIs do not help smoking cessation. Those are some medications that are often thought to be helpful. Naltrexone works through the opioid response system, where nicotine is more of a stimulant, anticholinergic, dopamine-driven system, and so while those systems interact, the medications do not help nicotine use disorder. Okay, so what are the FDA-approved medications for nicotine use disorder? And I will reiterate specifically that the FDA indication is for smoking cigarettes. So while these principles can still be used for vape and smokeless, they are technically still off-label and are done clinically, but most of the on-label uses are specifically for cigarette smoking. So we have 2 prescription available medications, varenicline and bupropion. Bupropion may look familiar to some of you. It also goes by the trade name Wellbutrin and is an antidepressant. Bupropion works on the dopamine system. It is a slight increase of dopamine and norepinephrine. It is felt to kind of harvest the craving mechanisms related to use disorder physiology. The varenicline is actually a blocker of the acetylcholine receptor, and which is what the nicotine sits on and activates. Its sort of mechanism of action, if you think about it, is to kind of take the joy out of the nicotine. So I had a patient once describe this to me, which I thought was the best description ever, so I have used it. It's like smoking and sitting in a cloud of the smoke, but not getting the enjoyment out of it, because the medication sitting on the receptor, blocking the nicotine in the product from activating the reward pathway that way. So these medications do work differently on different biological aspects of it. They can be combined in later levels of care for patients that may have failed, but they do have some unique properties. The remaining 5 products on this list are all nicotine-based products. The patch is considered a long-acting form. The other 3 are more short-acting or the ad lib versions. 3 of them are available over the counter, meaning anyone over the age of 18 can walk in and purchase them themselves. And many people do without guidance. If you just look at what the literature in the package says, if you're a high user, you may not give yourself enough. And so it is really important that even if someone is purchasing the products themselves, that we help provide some guidance and education so they get a dose that will be helpful to them. So the lozenge and the gum are available over the counter, and the patch is also available over the counter. The nasal spray and the oil inhaler, which I will talk about, are prescription options for that ad-lib add-on. I am not going to spend a lot of time talking about them unless you want me to, mostly because the nasal spray is crazy expensive. It is almost $400 a bottle. It is really hard to get people to pay for that if you've not failed other levels of care. It's the fastest acting ad-lib and can be really helpful, but is usually reserved for people that have had trials that have not been successful. And the oral inhaler used to be quite popular. It's something you hold in your hand. It kind of looks like one of those e-cigarettes in terms of shape. But the puffing action required to puff out the amount of nicotine requires almost 80 puffs an hour, and it's very difficult for people to extract enough nicotine out of that many people like it to hold something, and there are behaviors that can replace that as well, in terms of like holding a straw or doing something else with their hands, that the nicotine itself is not always as helpful or as immediate in extraction as the lozenges or the gum. So they are probably underutilized. I think they still make sense in patients that you can target, but just for purposes of this talk, I'm not going to spend a ton of time on those two because they are least used and usually more second and third line choices. The lozenge, gum, and patch we're going to talk about a lot. Okay, so this is where the milligrams matter. So the patch comes in 3 strengths, 7, 14, and 21. It's a 24-hour delivery mechanism. You put a patch on, it stays the whole day. You can combine patches, and if you look at those doses, it's a 1-to-1 equivalent. So if you have somebody that's smoking a pack of cigarettes a day, remember that's roughly 20 milligrams of nicotine, it's a conversion. So 121 milligram patch per day is what you would recommend you would put on someone use. Now remember, what if they're using 4 packs, like 1 can of smokeless, and you know they're using 80 milligrams. Technically, they might need 4 patches of those 21 a day. Now, I'm going to tell you that the data shows there's not a lot of data going above 3 patches, and there is a little. There's substantial data going up to 42 milligrams, though. So please do not feel like just because 21 is the max. If you know someone has failed 21, you know someone is clearly using more, at least going up to 2 21 milligram patches may be a better place to start. People are really good at self-monitoring their symptoms, and letting them also self-monitor withdrawal can be really helpful, and that's going to be important in understanding how the gum and the lozenges are used as well. But you want to think about nicotine replacement as putting the patch on that matches their daily use, and then we're going to use the gum and the lozenge as that ad-lib add-on when a craving comes through. And we'll talk about this a little bit more, but that patch takes a long time to kick in, and you want to have people sort of be able to reach something they can use when the craving breaks through. And so the nicotine gum and the lozenges come in 2 and 4 milligrams in the United States. In Europe, there's a 6 milligram version of the gum, but we do not have that commercially available here. And all of these are available over the counter. And we're going to talk more about how to use them. Okay, so the patch. The advantage of the patch is that it is really supposed to kick in and provide some long-term coverage. But if you've ever used a patch, you're going to put a patch on someone, they're not going to feel it. And so especially if someone is entering a situation like an airplane or a hospital where they can't use a device, while that patch may really help over the long haul, is not going to give anybody any relief for about 6 to 8 hours till it starts leveling off. And so it's important to remember that and why you will need to add something to it for those early cravings. It's pretty easy to use. The biggest side effect is often a skin rash or irritation, often rotating the site on the body, or even doing a little bit of hydrocortisone cream after you've removed it, not when you put it over it, can really help that. It's pretty well tolerated. There are very few side effects from the nicotine. The most challenging part of nicotine replacement is to determine if you're getting too much nicotine or not enough nicotine and having withdrawal. And so if you're getting too much nicotine, I think GI side effects, headaches, insomnia are clear, and the person in front of you can tell the difference usually. And so it's really helpful to talk about what they experience when they're in withdrawal, or if they feel like they've gotten too much, because that will be the same rules that apply for this. So how do you decide? And this kind of goes back to what we talked about with knowing those milligrams. If they are using more than 40 milligrams a day, the recommendation is to really start with 2 21 milligram patches. You will have clinicians tell stories. We had a story about someone who was using, I think, 2 cans of snuff a day, getting 5 patches and doing well. But the risk of getting too much nicotine, the nausea and the side effects is much, much, much greater if you go above 3 patches. And so it is usually that we start with 2. And so starting with 2 21 milligram patches, and the guidelines are to do that first step for about 4 to 6 weeks, with the idea of stepping down the dose by 7 to 14 milligrams every 2 to 6 weeks, depending on how they tolerate it. But because there's behavioral changes that go along with this too, the idea of whatever we need to do to help someone stay off the tobacco product for about 6 months allows that behavior change to really take effect. So this is really guided in discussions with the clinician about how they're doing. If they're feeling not ready to step it down, or there are a lot of triggers coming up, holding it longer is certainly safe. One of the things I tell people, giving someone nicotine replacement therapy is far safer than the nicotine they're getting through an inhalation device or smokeless tobacco. There's just no comparison in that regard. And so in some ways, although this is not the way, I would rather they stay on nicotine replacement forever than choose another device, because it's usually those carcinogens and the other aspects of the tobacco, the other aspects of the vape that's really causing the other health consequences in adults. That's not always true in pregnant patients in regards to children, which we'll talk about at the end if we have some time. But I guess my advice is don't rush people too fast through this. This is a guideline. And if your patient's having success, they don't feel like they can step down, it's okay to extend it as long as you need to. Sometimes availability of the product, and this is where our pharmacists often help us out sometimes limits and insurance do sort of set some of those limits for people. And so that's practical, but from a health standpoint, this is a better health choice. And then you can step it down. If someone's using a pack a day, around 20 milligrams, you can start with a 14 to 21. If they're using less than 10 cigarettes a day, you can use a 7 to a 14 based on that range. And you can combine them. You can have a 21 milligram patch here, 7 milligram patch. You can combine them any way you need to. I do believe, and correct me if I'm wrong, pharmacists on the call, but I think you can cut some of them. If you only have access to a 21 milligram, if you're using a free supply, or they have 21s and you're trying to step them down, you can actually cut the patch that way as well, and use it that way if you need to. That's correct? Okay, so the gum. The idea with the gum is to provide a faster onset for craving. So the idea is if you have a craving and you're starting to stop, we want you to reach for the gum or the lozenge to deal with that craving, as opposed to the cigarette or a vape device. And so I think the number one thing I see with gum and lozenges, people don't use them enough. And what you would do as a clinician is give people permission to use these like sort of PRN ad lib medications as often as they need them for their cravings. And then if they're needing a lot more than the patch is covering, you can adjust the patch in the following weeks to be more or less. And so these medications peak in about 15 or 20 minutes. It's still important to let people know that's not as fast as the cigarette or the vape, right? That was 7 seconds. This is going to take a little bit longer to kick in, but most people with a little bit of education can and some prep work can figure out how to ride that craving for about 15 minutes and find some ways to work through it with motivational techniques and planning. The important issue with the gum is recognizing who you're recommending it for and if you're giving instructions regarding how you use it. West Virginia also ranks up there as the #1 edentulous no teeth population. And so recommending gum for people without teeth doesn't go over very well. And so please be aware of that. TMJ often is worsened by this as well. So those are 2 populations we really would say consider the lozenge for instead. If you're going to use the gum, you have to tell people to not use it like chewing gum. If you chomp it up, you get all that nicotine in the saliva, you swallow it, you get sick. And so the way this works is extracting the nicotine from the gum across the mucous membrane. So you have to teach people the park and chew idea. So you chomp on the gum, it starts to tingle, or you get a little bit of taste, and then you park it in a little ball in your cheek. Let the nicotine absorb through the cheek. And then when the craving comes back or the tingling stops, you chomp it again and park it again in your cheek. You can use this gum every 1 to 2 hours, and that's up to 24 pieces a day. People are often, as they get motivated to stop, they're like, oh, I'm not going to use it. I'm not going to use it. No, you want to encourage people to use it, because using it and getting that craving under control or letting that patch kick in actually helps increase their chance of success. So one of the #1 things I've seen people do is not use it enough. To be honest, they're like, oh, I tried not to use it. I try to go, no, I want you to use it. That's exactly how we want to encourage you. So you really can use these very frequently. When you have the conversation with someone at the beginning, you have to know, do I recommend the 2 milligram version or the 4 milligram version? That also goes back to how high their nicotine use level is. And there are 2 easy ways to sort of decide if someone's in the high use category or a lower use category. So those 2 things are, how fast do you use your product when you wake up in the morning? If someone is using their nicotine device within 30 minutes of just waking up before they do anything else, that automatically is a sign most likely that they have a high use of nicotine. And those are the folks we would recommend 4 milligrams to start with on the gum. If they're using more than 20 milligrams or 20 cigarettes a day equivalent, that also might suggest they start with a 4 milligram dose. The lozenge is very similar to the gum in terms of the dosing and the rules, but you don't have to chew it. It's more of a just park it in your cheek sort of mentality. And I think a lot of people actually like, I would say most people like the lozenges better than the gum in my in my population, I guess. It, like the gum, and I didn't say this, can be affected by pH. So when you're using gum or lozenge, you really don't want to be drinking things or coffee or fruit juice, because it can slow or speed up the absorption of that. Especially if it's acidic, you're going to slow down the absorption of it. And again, this doesn't have the risks with teeth. The smokeless people using smokeless tobacco often prefer the lozenges as well. It sort of simulates putting something in your cheek like that. But it also comes in the same 2 and 4 milligram strengths that the gum does, and it has the same rules. You can give it every couple of hours. It says 2 to 4 there, but you really, again, it's the same kind of idea, and the same rules about, do I start with 2 or 4? Come back to those 2 questions. What's my total milligrams of nicotine being used today? And am I using within the first 30 minutes? So let's do a quick example with this, just to help kind of make sure people understand. Let's take just a simple example of someone smoking a pack of cigarettes a day. That would be 20 milligrams. If I was going to start with NRT as my first choice, that combination, how would I dose that? I would give them a 21 milligram patch, right? I'm using my patch to cover the closest amount of daily milligrams I can. And I would say, I want you to put on this 21 milligram patch every day. And then I'd have a discussion with them about whether they preferred gum or lozenge. And then I would say, you're at 20 cigarettes. If you've never tried it before, because we're right at that 20, I'd ask them how quickly they use. If they use up to, they're like, it's the first thing I do out of get. Okay, let's start maybe with the 4 milligram gum. If it's too strong, you can try the 2. And I'd say you can use this gum or the lozenge every 1 to 2 hours, roughly, anytime you have a craving until that patch kicks in. And when you feel like you need it, use it. We teach them how to use it. And then what I'll do is maybe in a week, see how they're doing. If someone is telling me, oh gosh, I'm still at like 10 pieces of gum a day, maybe they were underestimating how much they were using, I might increase their patch strength a little bit so they cut back on that ad lib. But it's also okay to encourage them to use that. And as they stabilize in the first 6 weeks and the behaviors and the triggers and the sensory environment, they start having an experience of success, we can start then talking about tapering down the road. If I had someone using a can of Copenhagen a day, that was 80 milligrams, I would start with 2 patches, right? I'd put on 42 because that's the max we start with. Now, as I said, sometimes people go a little bit higher. I already know they're using 80 milligrams, well over that 20 milligrams. So they're in the high use category. I'd recommend a 4 milligram lozenge as the ad lib around every 2 hours as well. Okay, that makes sense? Okay. As there are prescriptions for the nicotine replacement spray and the inhaler, I am going to absolutely go through those slides super fast because I already told you they're not used a lot. The information is there. We can talk about more in depth, but I really want to get to the prescription ones before I run out of time. Okay. So the first prescription medication is bupropion. We use the SR formulation because that is what most of the studies were done with. There is an XL formulation for depression that can be used sort of in the same way, but it is not the one that technically has the FDA indication. The bonus points with bupropion SR is this is a dirt cheap medication. It is on the $4 and super cheap list of most pharmacies. While this medication has more precautions associated with it and is probably underprescribed, it is the cheapest and probably the easiest for people to access. And so I think it's probably still underutilized a little bit for smoking cessation because of those warnings, but it sometimes is more accessible and easier to use. And so making a decision about using a prescription versus NRT really comes down to the convenience of what your client or patient wants. And for a lot of people, taking a pill, especially if they're already taking a daily medication, just putting in a pill box is often easier than patches or gum. And so the dosing on the bupropion, and this is the nicotine replacement dosing, is in the first 3 days, you take 1 50 milligram SR pill in the morning. And then in days 4 through 7, you add the second pill around 4 o'clock in the afternoon. Okay. Early evening. And we'll talk about that in a minute. So it becomes a twice a day, 300 milligram total dose, 150 milligrams twice a day from week 2 onward. Okay. This is where bupropion gets a little bit complicated. It does have, it's the one that's increasing norepinephrine and dopamine, really helping with cravings. It has some warnings associated with it. One, this medication has been associated in high doses with seizures. So anything that potentially can increase a seizure or an electrolyte abnormality or liver or kidney problems that can have that risk, you have to be a little thoughtful about that. It also is a medication that can worsen anxiety. So some patients get real cranked up. So patients with anxiety disorders can often get real jittery on this medication. However, because it's a medication also for depression, can be an excellent choice in someone that has straightforward like neurovegetative symptoms of depression and smoking cessation, and can be used in that population. But because of that seizure risk, the things that increase seizures, like an eating disorder with active purging, a history of head injuries, liver, kidney problems, a history of alcohol use that might also cause a risk of seizures, you're going to see those as labels and warnings. Now, some of that is, I think, fearful to providers, so I'm just going to avoid that one. But it also depends on how active of concern those things are. It is also a medication that carries a risk of suicide warnings, of ideations, in patients under 24. All antidepressants carry that warning in adolescents and patients under 24, and this is no exception. However, that's a blanket warning. It's really not been clearly linked to bupropion specifically in some of the studies, but that warning exists nonetheless. And so all of these warnings can make some people nervous about prescribing it, but there's a lot of patients that can do well on it. The other thing I will add to the bupropion is it's the one that is also used in weight loss, right? It's a combination and doesn't cause weight gain. And so it has shown to help mitigate weight gain risk with stopping smoking. I have a lot of patients that like that as well. Okay, varenicline. Varenicline used to have a lot of warnings. And a lot of studies were done to get rid of those warnings because they did not hold up when significant evidence base was done. So I don't want to go through what those warnings were and why they were removed. We could talk about that in a different conversation, but a lot of patients remember the warnings and we're scared by the warnings as we're providers. I think we're moving out far enough that that's becoming less of an issue, but those have now been removed. I think varenicline personally is one of the easiest medications to use and write, and one of the more safest medicines that you can consider. Compared to all the other things I write as a psychiatrist, varenicline just has a much better safety profile and is a lot easier to use. It was also the one prescription that had that 33% success rate. So its biggest barrier at the time it came out was cost and insurance. It has now gone generic. There were some production issues at one point, but it really is still probably substantially underutilized given its success rate. So it's the one sitting on the receptor, blocking the nicotine from giving the desired effect. So it makes people sort of not enjoy the nicotine effect slowly over time. This used to come in really nicely packaged instructions. So you get like a starter pack and have the pills labeled, and it was real easy to use. But you can also just write it as a prescription. And the way you write that is for the first 3 days, you take 0.5 milligram pills once a day. Day 4 through 7, you take the 0.5 milligram dose twice a day. And then in week 2, you go to the 1 milligram twice a day dose. That is the treating dose for at least 12 weeks. Now, I didn't say this with bupropion, but it's true because this blocks receptors and the bupropion increases release. Usually we tell people the full effect of these medications are going to take about a week after that steady state dose to really start feeling the effect. So if someone is really motivated to set a quit date, you would want them to start the bupropion varenicline at least a week before that so they'd have the full effect of the medication. That idea of setting a quit date has really largely left practice and is not necessarily necessary anymore, but it is the full effect of these medicines will take a little while to kick in, unlike the NRT, which is very fast. Okay. And again, I said this earlier, but smokeless, we can use all these products for smokeless tobacco. There's some evidence base and research of all of them in smokeless. However, it would be technically off-label. And I'm going to stop here because, as usual, my excitement has let me talk way too much. But in the slides that they will send out, I provide some additional information regarding tobacco cessation in specific populations, which we can talk about more if you'd like, but that's specifically what do you tell a pregnant patient or a patient that's breastfeeding, pediatric populations, and those with comorbid substance use, other substance use disorders, specifically opiates. There's some additional information that can help, but again, I hope I empower some thoughts that if you start with combination NRT or Chantix, varenicline as your first line, you can have substantial success. In clinical practice, if one of those fails, you can go to lots of different versions and combinations as your next line treatment. In fact, there are even 4th and 5th line treatment algorithms that might have you doing Chantix, bupropion, and NRT as options to help someone be successful. And so that's the driver of let's take what's working for this patient, let's make adjustments and really help have success. So I'm going to stop there and answer any questions.
Well, first and foremost, thank you so much, Dr. Swagger. You always do such a wonderful job, and you truly do empower everyone on the session, and you can really just feel the passion. And so we thank you for that. Any questions, comments from the group? Everyone's welcome to unmute. Mandy, yes, go for it. Oh, I think you're still muted. There we go.
Sorry, I was looking it up because about the patch cutting. So the Nicoderm CQ can't be cut, but there was a hot second when they had those patches that came out that had like the little pull aparts that you could pull those apart, technically not cut them, but they don't make those anymore. So it's a no cut situation now.
All right, take off the cutting, no cutting.
And I also want to add the comment, I'm shocked about the cans. I can't believe that's 4 pounds. I never knew that. That's mind blowing.
Yeah, and it is, and it's mind blowing to patients as well too. And so when you're talking about like, especially folks that have tried some of the stuff before and really haven't had success, really talking about milligrams, I think is really empowering because, like, of course you weren't going to be successful with the 21 milligram patch. We didn't give you enough, so let's set you up for success because it's not something people know, and I think it's also something that's not really talked about right in the nation because it's been such a targeted effect on our state that we have such higher rates that and I didn't say this, but there are other sort of measures that you can do to sort of calculate if someone is a low, medium, or high risk in their level of use. Those charts are in the bottom, and we have some treatment suggestions based on that. So there's some formal ways to calculate that too, but milligrams is probably the easiest way to do that. But I think it really helps people understand why maybe if they've tried something before they haven't had success and can really help them understand. And so I use it also as an education for our patients so they can understand as well. But the funny part about this, I went to the store the other day and was looking. I always do that before I give a talk. The price, a can is only about $6. And if you get a coupon, it's $4 or $5. So financially, that can is way cheaper than the cigarettes. The cigarettes are running 6 to 7 and are more expensive for less nicotine. So that also, if you look at the pricing of these devices in terms of, it makes no sense. But it is also why people have shifted sometimes to vape and the cans. It's actually cheaper for more nicotine. And some of that's also policy and taxation too, but from a healthcare perspective, it's actually a higher burden of need to meet.
I'm so glad you touched upon too that all patients, even cardiology patients, because I get a lot of pushback at Ruby when we have a patient that was there for an MI or something and they're smoking and we're pushing for NRT. They're always like, oh, well, I don't want to give them a patch. They're high risk for a heart attack. They just had one. I'm like, well, they're going to go home and smoke 3 packs of cigarettes. There's same risk. Oh no, they're just going to quit completely. I'm like, yeah, they're statistically, they're not going to quit completely. So I'm glad you touched upon that because that's huge. I see that a lot.
Yeah, it's actually the American Academy of Cardiology themselves that recommends every person admitted with a cardiovascular event, stroke or MI, should go home with one of those 2 products from discharge from a hospital. That is actually the standard of care. So the other sort of myth that is there is that you can't smoke on these products. That they used to say, if you smoke, we're going to rip it off of you. That's completely inappropriate. The idea is if you're smoking, that means I didn't give you enough to cover it in the first place. That's a sign that I need to give you more to cover your craving. And that is also old wives' tales at this point. And so, as I said, we really have to match what people need and help them understand that, because what happens, right? Oh, you just can't quit. This is a moral failure, or you just weren't strong enough. Nope, that's on us. So we really, really, really need to make sure that we give people what we need. And Cheryl's putting some great comments in the chat. I think that a lot of people don't know how to do this. I think this idea of this is really something our healthcare system needs to really make more at the forefront. In fact, I love this statistic, but for every $1 we invest in helping people quit tobacco products, we save healthcare $2. It's a very financially rewarding issue from a prevention and treatment standpoint, but it's not flashy, it's not successful, and not enough people know how to do that. So now you all know.
I love that. And Alicia, I noticed you unmuted. Did you have a comment or question?
Yeah, I just wanted to add for our Medicaid population within this realm to get coverage of the med, to refer them to the quit line.
Yes, and that number is in the bottom of the slide. When you call the quit line, they will register you. If you don't have insurance, they have some populations that can get you a free product through the Bureau of Health. But if you're Medicaid, they have to do the prior auth for the products. But they also offer through the quit line for coaching calls as well. So you get a little bit of the MI and behavioral support through the quit line. And so that number is 1-800-QUIT-NOW. And that information is also in the bottom of the slide. There's also tons of apps listed in that. There's apps, there's online resources, and other sort of self-help and educational materials in the bottom part of the rest of my slides. I knew I wasn't going to get to, but it is a buffet of support.
And as always, I'll be attaching your slides in the recap, so everyone will have those resources as well. All right, any other comments or questions? Cheryl has to hop off here, but she was thanking you, Dr. Swiger, for a great presentation. And I just have to say, Dr. Swiger, I love that you go and you saw like the prices before the presentation. That's such great information to know too. It really impacts everything. So thank you for that. Nick also chatted in thanking you so much. Currently supporting a loved one trying to quit and suspect they may not have received some of the clarity and or perform some of the treatment nuances you highlighted. Thank you for adding that, Nick. Any other comments, questions from the group? Another thank you in the chat. So I will just echo what's coming through in the chat here. Big thank you to Dr. Swiger for actually ending the year. This is our last Psych Echo for 2022, which is crazy. So thank you for ending us strong for the year of 2022. And you are actually the next presenter also for 2023. So you're going to be starting us off strong for the new year as well. But yes, so the only announcement is that the next session is on January 4th. So that is really crazy to say that we are already at the end of the year. Dr. Swiger is up to present next time on ADHD diagnosing part 1. So keep an eye out for that reminder. Mandy's excited, as we are as well. So just wishing you all such a happy and safe and filled with lots of yummy food, I hope, holiday season. So stay warm. Thank you all so much. We're going to miss you. And you are welcome to continue submitting any questions or cases throughout the holiday season. So appreciate you all so much. Thanks, everyone. Take care.